So I come from the planet Cancer, and my work there, though, I think is conceptually relevant to the work that you all do. So I'm an intervention researcher. We develop and test programs and solutions to try to eliminate health disparities in cancer. So we create solutions for vulnerable populations to do things like change behavior, increase screening, et cetera. And I'm pretty frustrated with that. And I'm frustrated because we've developed over the last couple of decades lots of very promising solutions. And despite our commitment and best efforts to get those out into the world, into widespread practice, our best successes look pretty local or regional. And they are not doing enough to move the needle on public health. So we've tried to think differently about this. And I hope the ideas that I'll share with you today will supplement the very many good, important lessons that you've heard from the other speakers. So no disclosures, but I do want to acknowledge a handful of folks who've really helped me develop the ideas I'm going to share with you. Peter Hovman, Jay Bernhardt, Chris Casey, and Jim Deering. I want to start with a question. Hopefully you can see this. If not, just play along. Here's a question for you. Multiple choice question. If you would put your check in the top box here, raise your hand. You've got to choose one of the two. The question is, which do you want? And the top question is more dissemination knowledge, and the bottom choice is more dissemination. Who wants more dissemination knowledge? Okay, good. Who wants more dissemination? All right. So it's kind of a false dichotomy, right? I mean, everyone in the room would like both of them, probably. I want to declare my bias here, which is, without hesitation, I check the box at the bottom. And the reason that I start with this is to make what I think is a very important distinction. We've heard at least 4 times so far today the difference between necessary and sufficient. Getting more knowledge about implementation, about dissemination, is probably necessary to get more dissemination. It sure as heck isn't sufficient. And if that's as far as we go with it, is to generate more research-based knowledge about the process of dissemination and implementation, don't count on that delivering widespread use of what we develop. That's one point. The second point, and I think this is much more important, and it's really the focus of the talk today, is that the activities you undertake to get more dissemination and implementation knowledge are very different than the activities you undertake to get more dissemination. They're very different. And I want to illustrate this with this map, which to those of you in the back of the room looks just like a green blob. If you're closer, what you can see is this is a map of crude oil production in the United States. And there are a couple of states that are very dark green: Texas, Alaska, California. And this is a bright group of people. I could give you the challenge. I could say, let's come up with a plan. Let's spend some time thinking about how do we get this crude oil from the point where it's produced in these oil production states to refineries around the US so they can convert it into products that consumers can actually use. We could solve that problem conceptually here in this room. We could study it and figure it out. But at the end of the day, you still have to have one of these. You've got to have the infrastructure and the systems to move things from the point of development, crude oil in this case, to the point of use by other people. And this is the piece that in so much of our health research is absolutely missing. It's not that we don't do it well. It's not that we're not trying hard enough. We don't even have it. We don't have the infrastructure that we need. And without it, we're going to continue to be frustrated at the level of uptake of our solutions. I'm going to talk about, in my slides, programs, because that's sort of the language that we use. We develop and test programs. I've heard this morning treatments. I know some of you work in the realm of assessments that might come from this work, or interventions, which I guess is a nasty word here. So when you see programs, think about the work that you do in sort of applied research. Here's the talk. I'm going to go through 3 propositions, and I'm going to try to defend those propositions, and then at the end I'm going to present to you a system that I think would overcome some of the important limitations that we have. Proposition number 1, and I apologize if yours is one of the programs that I'm talking about, but many, and in fact I think I could make a case that most of the things that we develop as researchers even the ones that are efficacious in rigorous research, are not worth disseminating. And we have to accept that, and we have to do a better job of figuring out which ones are and investing in those. Why do I say that? Here are a couple of examples from domains outside of health and research, and I think we should be looking to those for examples. This is from a study of technology products and what actually makes it to the market. And this funnel that you see starts with 3,000 raw ideas for technologies that could become products. That ends up becoming about 100 exploratory projects. Some of those become, a small portion of those become well-developed products. Just a handful, maybe one or two of those will be launched as products. One will succeed. Many worthy ideas, many pilot projects, very few successes. The same thing can be seen from US patents and trademarks. Over 250,000 applications per year go through the US Patent Office. About 60% of them are approved. A very small percentage, 2 to 3% of those are actually ever licensed. And of those that are licensed, even fewer are actually used. Many worthy ideas, very few end up being used. And the last example from our own work, this is a web-based and online tool that we have, MEO. It stands for Make It Your Own. It actually allows organizations to create their own customized versions of evidence-based communication tools for cancer prevention and control. And it's being used pretty widely with about 500 organizations in all but one state. And we did a little case analysis in 3 of those states, and we wanted to find out, why do people use it and like it? And these are the answers that they gave. And the important point here that I'm certain those in the back of the room cannot see is that the fact that it delivered evidence-based tools, community guide recommended evidence-based tools, ranked 10th. It was the 10th reason that they used it. What was above it? All sorts of things. It helped them solve a problem that they were trying to address. It was easy for them to use. It gave their partners something that they valued. It let them customize things for their local population. Those were the reasons they liked it. The fact that it was evidence-based, maybe. Evidence-based matters to everybody in this room, as well it should, but we should quit pretending that it matters as much to practitioners in the field as it matters to us. It doesn't. Think about this. Think about each dot on this line as a program or some sort of a solution. And we like to classify these as scientists along a continuum of evidence. We like to know what has strong evidence and what has weaker evidence. Or as we've heard today, we like to know for which of these do the benefits outweigh the possible costs of it. So we can look at this, we can look at an evidence-based continuum, and frankly, this is what we do, and we're very good at this as researchers. But we need another dimension. We need the dimension that I'll call demand. And the demand is the demand from the organizations that might actually use it, the clinicians, the practices, the schools. And if you plot those same solutions along 2 axes, not just evidence but also demand, I can make a case that I'll live with a little bit less evidence if there's high demand, if the goal is to get things into practice. I believe you can refine and improve on efficacy, but you can't magically create demand for something that people just don't want or that doesn't fit in the way they're doing things. So we need not just evidence-based programs and solutions, we need evidence-based programs that are in high demand. Second proposition, and you've heard a couple of versions of this in prior talks. And again, we'll move on. Most of what we do, most of what we make and test in research isn't ready for use in practice settings. Often it's not even close to ready for use in practice settings. And so if we want it to be used in practice settings, let alone be used by many different diverse populations in many different diverse settings, we have to be able to adapt it. I'm going to tell you the story of Newman's own dressing. Does anyone have some of this in their refrigerator? All right, excellent. So the late Paul Newman knew his way around a kitchen, and one of the things that he liked making was salad dressing. And he made salad dressing in part because he was so unsatisfied with the salad dressing he could get in restaurants. He would go to restaurants with his wife, or they'd go out with friends, and it was so bad he would begin bringing his own little jar of his homemade, kitchen-made salad dressing. And you can imagine the reactions. So at first, the reactions from the people dining with him are embarrassment. Oh, God, Newman's got his jar out again. And then they tried the dressing, and it was pretty good. And it was so good that they began asking him for it. Well, would you make some for us? Could we get some? And then one of his friends who had a business mind said, dude, sell it. And so, and hence was born what we now know as sort of the Newman's Own brand. But the Newman's Own that's sitting in your refrigerators is not the same as the Newman's Own that he would make in his kitchen and carry to the restaurants. It's got some different ingredients in it. He's got to stabilize those ingredients so when they sit on delivery trucks and they sit on shelves, they don't completely separate or whatever you don't want salad dressing to do. So he's got to tweak it a little bit. And then it has to be adapted because not everybody wants or likes the same salad dressing that Paul Newman and his friends liked. So you come out with variants of it, tweaking it for different populations. I think you see the analogy. What worked, the evidence-based salad dressing that came out of Paul Newman's kitchen had to be changed when it was taken to scale. And it had to be changed for different kinds of users who would use it. We have to be able to do that for our scientific solutions as well. And the third proposition, present company excluded, of course, is that scientists who make interventions, oh, that's a bad word, programs, treatments, for the most part, are really lousy at dissemination. And the sooner that we embrace that and accept it and stop pretending that we can become great disseminators, I think the field will be better off, assuming we can partner with people who do have those skills. So I want to illustrate this point by taking you through what a marketing and distribution system does from the world of business. And I think you'll see very clearly how our operation in the scientific community holds true to a certain point, and then it falls off the map. So I want to show you what these systems do, which they exist solely to take products and services from the point of development to the point of use, which is what we're trying to do with our treatments and programs. And I'm going to use the example of the automobile industry. Okay? So in the automobile industry, let's start with some market research. So there are people who are trying to figure out, what do consumers want? Oh, they want minivans? Not anymore, but they want minivans. What do they want in a minivan? Should it have 18 or 25 cup holders? So they figure this out, okay, and they have some sense about what's needed. This is very much like, the surveillance that we do in our fields. It's very much like audience research that we might do around a solution. And then that information is turned over to somebody who comes up with an initial concept design for a product. This is us. This is the researchers in the room writing a grant proposal. I think I know what people want. I think I know what the field needs. I'm going to write it out. This is what we're going to do. Please give me money so I can do it. And then it gets funded, and they move forward. And it starts as a prototype. And that prototype, if there's success and interest, becomes a working prototype. And that working prototype gets tested, but first in controlled settings. Okay? Let's just see if it does the kinds of things that we think it will. Let's make sure it doesn't hurt people. Let's do some safety testing with it. And then, and only then, would we take it out into a real-world setting. But it's not a real-world setting. It's not a real road. It's a parking lot with some cones. And this is what we call an efficacy trial in our work, for the most part. Okay? This is our efficacy trial. And the car performs well in the parking lot. Our intervention does well in our efficacy trial. And we write it up and we champion it, and we want and kind of hope people will use it. We submit it to to one of the online databases that will allow people to access it, and we hope things that are good happen, and usually they don't, and then we're on to the next thing. So the analogy works to this point, but what I want you to see is everything that happens in the automobile industry after you get to this point, because it's dramatically different from what we do. Okay, so you're going to take this pilot trial, and you're going to make it available to everyone. Well, first you're going to have to make some tools so you can produce it in larger numbers. You're then going to produce it in larger numbers. And then with cars, These don't roll off the assembly line and into your driveway, do they? No. So they go on to trucks, shiny red trucks. And the red trucks take the products to dealerships that are located where people live, near where people live who are going to be buying cars. And they don't trust that you're just going to wander by, oh, look, there's a car. No, they advertise. They generate demand and drive you to the dealerships. And if you go to the dealerships, you can see the products. And you can talk to people who know about the products inside and out and how they might work for you. You can test drive them. You can try them out. Does this product work for me? Let me give it a spin. You can compare the product to other alternatives that are on the market using some standardized metrics. If you decide to dive in, there are friendly, very friendly people who can help you acquire the product. If your product breaks, they have a whole industry of people who can fix the product. If something new comes along with your product, they'll let you know, look, there's a new version, there's an update. Okay? All of this is baked into the system. We have none of this, for the most part, in the world that we live in. What are the key points to take away from this distribution model? First of all, every one of those responsibilities is assigned. It's somebody's job. They wake up in the morning knowing that their professional identity is to drive the shiny red truck with cars. That's their job. Think about your identity as a researcher. None of us wakes up thinking that they're going to do any one of those steps along the line. And even if they were, you're not trained to do them very well. Second point, specialization. The person who wrote the grant, who designed the car, is not the person who drives the shiny red truck, is not the person who repairs it when it's broken. And lastly, all of those functions, while they are specialized and assigned, they all work seamlessly together. So if we're going to build a system that would support this sort of dissemination and implementation of our science, I think it has to do three things. It has to take evidence-based solutions and make them ready for practice by taking into, we first have to figure out what people actually want. So it needs to be a demand-driven system, not just an evidence-driven system. It has to be a system that can take scientifically tested tools and adapt them so that they're actually ready for practice and can be modified for different users. Whoops. And we have to be able to promote the use of those and actually support them and help people to use them. So I'm going to talk about three additions to our current model that would accomplish this. And this is going to be hard to see, I fear, from the back, but you've got the slides, the microscopic slides in your book in front of you. If you have binoculars with you, you'd be able to see them.
If I see a pattern, do I get a prize?
Granny's prize box. So the dots that you see here on the left, these are solutions that we might be testing. And we go take them through an expert review process, and we narrow them down to some subset that are empirically reviewed. And we have great systems for doing this. Our journals do this. Our scientific peer review for grants does this. Our systematic evidence reviews do this. We're really good at this. All of this is in place already. What we need to do is add to this what I'll call a user review panel. Some body of practitioners and leaders who are working in service delivery and clinical care in your work, who can look at these and say, okay, of the stuff that you have evidence for, here's what we really could use. This is what we would use. And that's going to narrow the subset a lot. Now, there's an important ancillary benefit of doing this, which is the decisions of that sort of a group are going to inform future research that gets developed. Once you know what people need and what they're looking for, you can develop and test solutions that meet that. The next thing we're going to do is we're going to unleash a new unit, a design and marketing team, to take those solutions, those treatments that are both proven scientifically and have user demand, and they're going to make them better, and they're going to make them ready to use. So what you're going to end up with at the end of this process is a menu, if you will, of evidence-based, high-demand, practice-ready solutions. And that's going to grow. That's going to constantly be growing. And then what you want to do is have a cadre of people, boots on the ground, if you will. I'll call them dissemination field agents. And their job is to get that menu, get items from that menu into practice. how can I work with you, clinician, to figure out which of these solutions is going to work for you? Let's help you choose what would work for you. Let me help you implement it in a way that fits your particular context and settings and populations. And if you have problems, if you have questions, I'm right here. I'm right here to help you along the way. And there's also a collateral benefit here, which is those boots on the ground are going to figure out pretty quickly what's working and what isn't. And they're going to be able to feed that back into the design and marketing team for a process of constant improvement. 3 things that we could do: a systematic user review process, design and marketing teams to take scientifically tested products and make them ready for practice, and dissemination field agents to actually help people adopt, choose, adapt, and use those solutions. Thank you.
So this sounds like a wonderful system. There's just, oh, I'm sorry, I'm Maria Paul from Sacred Heart University in Connecticut. There's just one difference that you didn't mention between the car company and what we do, and that is that people pay for cars.
No.
So that generates the profits to support all the rest of the system.
Absolutely.
So who pays for all this?
Who do you think would pay for all this?
I'm asking you. I don't know.
I have a lot of practice answering this question, as you might imagine. It's always the first question that gets asked. I would say this. Number one, in my world of public health, particularly thinking about solutions for vulnerable populations, there are many organizations that need what we do. There are very few that have large discretionary resources to pay for it. And there aren't a lot of businesses lining up saying, hey, this looks like a great business model. Let's try to sell things to organizations that are resource poor. So if that's the reality, how do you overcome that? So I think there are a couple of answers. One is, if we believe that as a society we're going to invest in research to try to come up with answers to problems, and we get answers and we let them sit on a shelf, that's poor value. Okay? And so that is, in fact, the role of government, when markets won't step in to solve a problem and you've got some social good that's at stake. So I think I could make an argument that there are federal agencies who, in fact, should be doing exactly what this sort of model suggests. That's one explanation. The other explanation is, frankly, the research community has an enormous stake in this. How long do you think billions and billions of taxpayer dollars are going to go to fund research that doesn't improve people's health or improve their lives? I mean, I think we're kind of wearing out, our welcome, if you will, in that regard. What if some portion of the research enterprise didn't just fund more research about implementation, but set up systems through which these sorts of solutions might be addressed? So I think those are a couple of possible ways that you could fund a system like this. Go ahead.
I'm Steve Camerata from Vanderbilt University. So I find this all very intriguing, and actually, just as a comment, I saw a lot of the elements that Dr. Horner presented. Clearly there's some overlap here. It's not cars, but it is systems change in schools. My question is really in the treatment domain. Kind of the entree into this system was consumers choosing, and I'm thinking about your area of cancer research. Patients don't really choose their treatments, and so I was wondering, how. We have a situation where you have practitioners that are essentially providing the knowledge about the treatments and how that fits into your model.
So I think the best way to answer that question is to clarify who I see as the consumers for the sorts of treatments and programs that we're talking about. It's actually very much like the distinction you made in the last talk between school boards and actual schools and the students themselves. So the students and the families in this example were the ultimate beneficiaries of this, as they are with the work that we do. But they're not the consumer. The consumer, in my view, is the organization that's going to adopt some practice that is going to become, it's not going to be at the discretion or choice of the consumer. It's going to be the agency or organization that is serving them has decided to do things in a certain way.
Thank you. Truman Coggins from the University of Washington. I was motivated to ask a question when you got to Newman's salad dressing. I was one of the guys that raised his hand. But more to the point, Not only are we researchers, but many of us in this room are also teaching on a regular basis with our students, both at the undergraduate and the graduate level. And so I'm thinking about curriculum and trying to get people to think about ideas in different ways. And I wanted to know if you have some thoughts or ideas about an undergraduate curriculum, and if we should be thinking about market research, certainly at the undergraduate and graduate levels, or different ways of thinking about having our students come up with these innovative ways of solving problems.
That's a great question. Here's what I think. I think it would be wonderful if people in our discipline knew how to do all those things, and I think you wouldn't get any of your core curriculum taught if you aspired to do that. I think the best we can hope for is to introduce them to some ideas and concepts from some of these related fields, and to take a truly transdisciplinary approach to education, where you have them think about solving problems in the field not from their sort of narrow, siloed disciplinary perspective, but what do all of these other fields already know that can help you solve that problem, and in part teach people where to look for help and how to convene teams of people who know and do different things. Science is about knowing. This is really about engineering. This is about doing. This is how do you get solutions into practice, and it's not a part of my training in public health.
I'm Pam Crook. I'm from Social Thinking in San Jose, and I'm here in a little bit of a different role, I believe, than most of you. I represent sort of the end game that you're talking about. I represent a particular framework, kernels, evidence-based kernels that have sort of taken on a life of their own. And as Ria came up and mentioned the piece about funding, where do we get the funding? I think partnerships, that's where the funding, that's where it would happen. There are groups within our field in communication sciences who are making the end part happen. Clinicians are taking off. PBIS is a great example. Social thinking is a great example. It's used by thousands, perhaps millions of practitioners and families. So I'm here to help figure out how do we make those relationships come together between university folks and sort of the end game folks, so that we can find that evidence connection between the two. So I appreciated this piece.
Thank you. And I would just, if I can respond.
Put in one thing, go ahead and respond, but I just want to make sure I got my 2 cents on.
I was going to apologize or maybe soften a bit my statement about we have a complete and total absence of this. The truth is there are people who are working in this space, and you need to partner with them. We don't have systems at sort of a national level that are available for everyone necessarily, but there are people who are working in this space. In fact, I shared a ride from the airport yesterday with one of them. Go ahead.
I'm Mary Wilson from Laureate Learning Systems, and I was formerly at the University of Vermont. But I would like to point out that actually the government has gone in a different direction than what you are suggesting, in that the SBIR program, which was introduced in the 80s, and then was supplemented by the STTR program, which is designed to have these kind of collaborative processes between the private sector and the university, is actually being slashed. And when it came to the NIH, they have systematically excluded SBIRs from many of their initiatives.